Let's think about what aphasia rehabilitation would look like in the future. Let's imagine that a patient goes to the hospital right after he has a stroke. And once he's discharged from the hospital, he is sent to a lab or a clinic where he gets a complete neuroprofile done, an MRI scan, resting state, fMRI and DTI and so forth. He also gets a language or cognitive workup done and a comprehensive language and cognitive assessment battery. And he also gets a social profile, a functional profile workup done. What was his occupation? What are his functional needs and so forth? And all this information then gets into some sort of complicated algorithm that can then predict that particular individual's prognosis and recovery trajectory. Based on the outcomes of that trajectory, he will get a fairly precise recommendation of whether he should pursue intensive aphasia therapy and individual therapy, or he should go after some individual therapy and join social groups, or focus on social groups and vocational training. Now, clearly, we're not there yet, but the work that's done in my lab is trying to chip away at many of these factors. So the theme of what I'll be talking about today sort of breaks down into these different components that we think are important. I will talk about neural markers of language recovery and the work that we've done there. We've also looked at language and cognitive markers of language recovery, as well as worked on effective treatments for patients with aphasia. I won't talk as much about that today. And then I'll spend the second half of the talk talking about our ongoing work on predictive modeling and how that can better inform patient treatment outcomes as well as prognosis for patients. So that's sort of the outline for the talk today. So let's step back and take a look at what constitutes neural recovery in aphasia. As most of this audience knows, a lot of work has been done in the last 10 years to help our understanding of language recovery. And it turns out that the initial few hours and days after the stroke is really critical in terms of how much tissue reperfusion happens. That's work by R.G. Hillis. And as the patient recovers in the weeks and months after stroke, Dorothy Sauer has shown elegantly that there will be some right hemisphere upregulation over the course of that 1 year that then downregulates. What really matters over the course of the recovery is how much left hemisphere upregulation that you see, and how much of this left hemisphere activation comes back to being what normal people show. And in the chronic phase, what seems to be really important is the establishment of new pathways and compensatory mechanisms. So in this chronic phase, there's a lot of studies that have looked at the neural correlates of language recovery in patients with aphasia. There's a ton of studies that have shown that right hemisphere supports language recovery and or is recruited during language treatment. And these studies, for example, show that there are critical regions in the right hemisphere, including IFG and SF and STG. There are also studies that show that better recovery and treatment outcomes are achieved when activation returns to the left hemisphere. And these are all the studies that have looked at recovery. And as you can see, left hemisphere RFG is a critical component that is associated with better recovery. And of course, there's a lot of studies that also show that behavioral recovery is associated with activation in both hemispheres. And now we've got studies that have shown activation in both sides as well. So this complexity clearly has not been resolved, although Peter Turkeltaub in 2001 showed very elegantly in a systematic review of studies that as long as you did not have left hemisphere IFG damage, those regions were active during language processing tasks. But when IFG was damaged, activation shifted into the right hemisphere in the same homologous regions. And the assumption is that when language areas are damaged, there's a release from inhibition, and you start to see an increase in right hemisphere participation for language function. Now, in our own lab, Raji Sebastian, when she was doing her dissertation, we looked at a small group of patients when they were doing a semantic judgment task and a picture naming task. And what she found was that when patients were doing the semantic judgment task, it was primarily activation in the left hemisphere ipsi lesional regions. But when they were doing the picture naming task, the activation was bilateral. And so we concluded that depending on the task demands, patients could show left hemisphere or bilateral activation. You could see that in the same person. Similarly, Rashni and Shalise and I looked at 3 patients with bilingual aphasia, and they were doing tasks either in English or Spanish. And what we found was when they were processing words in their dominant English language, they showed left hemisphere activation, but when they're processing words in their less dominant Spanish language, they started to show bilateral activation. Again, the same person can show either left or bilateral activation depending on the task demands. So in a follow-up study, Jordan Sims looked at to what extent the integrity of the left hemisphere did influence the amount of activation you saw in both hemispheres. So this was a study with about 15 patients, and she essentially quantified how much lesion there was in the left hemisphere, and what she and correlated that with the amount of activation in left and right hemisphere regions. And what she found was that the more the damage to LIFG, LMTG, angular gyrus, and supramarginal gyrus, the higher the percent signal in bilateral frontal regions, specifically in SFG, MFG, and ACC. And the assumption or the conclusion here was that there is this bilateral frontal network that seems to serve an assistive compensatory network, sort of a backup support network. She also looked at correlations between regions in healthy controls as well as patients. And there the controls, healthy controls, showed a left lateralized network, which was bilateral, but it was left lateralized. But in patients, that activation shifted to this bilateral frontal network, as well as regions here. So it sort of went to the frontal part and the right hemisphere. So one of the things we all know is that activity patterns and language abilities are not always restored by the chronic phase of recovery in aphasia. So there is a model or explanation that Heiss and Thieleff provided in 2006 and 2014 that there's a hierarchy of recovery that happens. The optimal recovery, the best recovery, is when there's only minor damage to the left hemisphere and regions that are not central to language are not affected, are not completely affected, and there's complete recovery of function. There's this satisfactory but incomplete recovery that you see where there's damage to core left hemisphere language regions, but there's perilesional tissue that remains functional, and that can support language recovery. And then, of course, when you see poor recovery, we're talking about extensive damage to the left hemisphere language network, and now you only have homotopic right hemisphere regions that remain for language. Now, what I'm going to propose here, and this is really work from by Erin Meyer, who's finishing up her dissertation right now, is that there's a slightly more nuanced way to think about this hierarchy of language recovery. So what you're looking at here is a schema where if there's no damage, as you would see in healthy controls, you have a bilateral network which is left lateralized for language processing, and that's associated with normal language processing. Then the next best case scenario is when you have posterior damage, but you have regions like IFG and MFG intact, and then there's this sort of shift bilateral frontal as well as right hemisphere, and that's still associated with good language performance. Then you have the next case scenario where you have damage to the anterior regions, but it spares MFG, and that's associated with sort of less better intact language performance. And then the next two scenarios, number 3 and 4, are when there's extensive damage to the anterior, the frontal and temporal regions, as well as when the damage is entirely to the left hemisphere regions. Now you start to see activation completely shift over to the right hemisphere, but that's associated with poor language recovery. So this is a hypothesis, and what we're trying to do now is see if this is really true or not. So I already talked a little bit about our imaging work with relation to fMRI. So I'm going to try to focus on ongoing work right now. This is really stuff that we're just working on in the last few months, last year, and that sort of looks at structural indicators, gray matter and white matter indicators, as well as connectivity methods So the first study I'll tell you about is work that Erin has been doing. This includes 30 patients with aphasia. They are all getting methods in terms of calculating the structural integrity. And what I want to emphasize is a couple of steps here, is that for this particular analysis that I'm going to present, we're looking at 3 indicators. We're looking at gray matter integrity. We're looking at white matter underlying the gray matter integrity, and we're looking at fractional anisotropy and MD integrity right adjacent to those gray matter areas. So we've divided the brain into ROIs, and we're looking at 3 metrics: gray matter integrity, white matter underlying that gray matter, and FA and MD adjacent to those. I hope you can hear me because it says that there's some poor network. So I'll just keep going. So for example, here you can see that we can calculate specific regions of interest in terms of their gray matter and white matter integrity. Okay, great. So what we did after we got those ROIs and we looked at gray matter, white matter integrity, as well as FA and MD values, we extracted 10 components using principal component analyses, and then we took those and then we put them into first a backward stepwise regression model, and then in the data that I show you, we looked at the significant models there. So these are the 10 components that essentially came out. As you can see, there's gray matter integrity, white matter, and so forth. So in the first analysis, we looked at just overall aphasia severity, and in that case, what we found was that 4 components significantly predicted WOB-AQ, and the first one is the most obvious, which is the amount of tissue that's spared in gray matter regions, and that's this line here. And then we also found that the integrity of LIFG and LMFG also predicted the performance on the WOB, as well as left hemisphere prefrontal diffusion, as well as right hemisphere MD values. And those are negative because we're looking at MD values in both of these cases. But the relationship towards WOB aphasia quotient is sort of the same in all cases. The higher the WOB aphasia score, the better the integrity of these regions. Then we looked at how these models predicted naming performance, because that's what we're interested in as a behavior. And of course, compared to the WOB-AQ model, there are fewer structural metrics, but they included LIFG and LMFG, as well as left prefrontal cortex diffusion. Again, the more the spared the LIFG and LMFG, the higher the naming score on our naming screener. And then finally, we looked at how these pre-treatment metrics baseline metrics predicted treatment outcomes. So now we're looking at how these measures predict gain as a function of treatment. And what we found was that, again, LIFG and LMFG, ventral temporal integrity, and left prefrontal diffusion predicted the outcomes. Again, the relationship is sort of the same. The more the spared the tissue these regions are, the higher the gain as a function of treatment. Okay, so this going back to what I had started off with here, what we're seeing here is sort of this notion that the more the spared the tissue, especially LIFG and LMFG, the better the language performance on the WOB, as well as in this case on the naming screener as well. The more the integrity of the white matter adjacent to these regions, so we're sort of looking at something here, again, the better the language performance. And in the case of the treatment outcomes, the more the integrity in LIFG ventral temporal regions and this diffusion, the better or the more gains the patient makes. So the closer they're getting to normal-like performance. Okay, so that's one piece of evidence. So I'm going to move on then to our connectivity data, and this means we're looking at functional data, task-based fMRI. We're also looking at resting state fMRI, which I'm not going to talk about today. Sorry, that should say RS fMRI. What we're doing in connectivity is we're looking at it 2 ways. We're looking at diffusion, we're looking at dynamic causal modeling, as well as functional connectivity. And one of the methods things I'd like to get out of the way first is that we're very careful about where we're looking for activation. So here's just some steps that we follow. We first look at activation in regions for either the patients or the controls to identify the voxels of interest. We then create bounding box, anatomical bounding boxes around it to make sure that we are looking for centroids here. We also calculate every patient's lesion maps, and then we take that lesion map and overlay it on these anatomical regions of interest that we've got, and we calculate the percent spared in each of these regions. So for example, here you can see that based on this lesion mass, this person has 60% LIFG tri spared and 58% LMTG spared and so forth. And then we check, again, that the activation that we're looking at, and you can see this in these yellow circles here, the activation that we're going to take over into our function analysis is not in that lesion area, and it is within that anatomical bounding box that we had defined. So it's actually activation that's present. So in the first study that I'm talking about, we weren't that careful about doing this, but since we've gotten very careful about making sure that all these steps are true. This paper had come out a couple of years ago. In this case, Aaron was only looking at 3 nodes in a network, LMTG, LIFG, and LMFG, all in the left hemisphere when patients are doing a picture naming task. There were 13 patients in this study, and she looked at a lot of models, but then you can divide them by families. And what the results showed was that when controls are doing this task, the winning family model is input to LIFG. That's no surprise. But when patients are doing the task, the winning family model was actually input to LMFG. And then we looked at a lot of relationships between the connectivity strength and performance inside the scanner and outside the scanner. And what we concluded in that study was that LMFG was critical in the recovery of the left hemisphere naming network. And then in a follow-up study, same 3 nodes, LIFG, LMTG, and LMFG, different task, a semantic feature verification task, slightly more patients now, and the same methods. And now what we found was both controls and patients have a winning model that's input to LMFG, but this effect is much more defined for the patients. And so what that meant was when we actually looked at the connection strength between these 3 nodes and compared it for controls and patients, the modulation of LMFG was actually stronger for patients than controls. But in this 3-node network, all the 3 nodes were equally important. So what we found was there was greater modulation of LMFG on LIFG for patients than controls, but higher task ephemera, the task accuracy was related to this connection between LMTG and LIFG tri for the patients, and performance on an offline semantic task was also related to activation in LIFG and LMTG. So what we concluded was that LMFG, middle frontal gyrus, is an important modulator for these patients, but it's not working alone. It has LIFG and LMTG sort of also working in order to accomplish the task correctly. So in this study, we only looked at 3 nodes. It was only in the left hemisphere. So in the next study, we sort of took a step back and looked at many more regions. So now you're looking at something that resembles that initial hypothesis that I showed you. We've got more nodes in the left hemisphere and the right hemisphere, and now we're essentially comparing different sets of models. The first one is a completely normal left lateralized language network. The second one is when you have posterior damage, so you'll find we're looking for connectivity in the front. The third is an anterior damage, so now we're looking for connectivity in the back and right hemisphere. And the fourth is an extensive damage to the left hemisphere model, so now we're looking for connectivity in the right hemisphere. There were 34 patients in this study, exactly the same task. And what we found here was that, like you would expect for healthy controls, there's a left lateralized winning model that resembles what we see here. For patients, that model is also a strong model, but there's also a family 3, which essentially is anterior damage, posterior connectivity. When you look at the connection strengths between patients and controls, as you would expect, the connection strengths are strong for the healthy controls in the left hemisphere, and there's this posterior connectivity that's also significant. The patients in general show lower connectivity connection strengths than the healthy controls, and you can see right away that it's sort of significant for LIFG and LMFG, but there's also these connections here in the right hemisphere that withstand the statistical tests. Now, going back to what I was starting to tell you about, these results, again, a different set of results. These are fMRI, dynamic causal modeling data, still sort of seem to be aligned with what we were thinking, which is when you have LIFG and LMFG intact, when it's spared, they do modulate task performance, especially when these patients are doing the semantic feature task. But they're not the only regions. There's also this third model that was explaining a lot of the data where there's this posterior nodes in the network that seem to play a role, as well as right hemisphere regions. So we're somewhere here still trying to explain this in the form of a network. No one region is actually carrying most of the load. So that was all dynamic causal modeling, looking at effective connectivity. We've tried to look at the same problem from a different perspective, and this is functional connectivity data. This is 26 patients. It's a subset of the patients I talked about before. 17 age-matched controls. They're doing a picture naming task now. The previous one was a semantic feature task. And now we're looking at just the connection strengths between regions that we've already pre-selected. So we have 38 bilateral ROIs that we're interested in because they're all involved in naming. And Jeff is the person who's done all this work, and we're using the Con toolbox to do this analysis. So what you're going to see here is first healthy controls. Warm colors here indicate significant positive connections. Cool colors indicate significant negative connections. And when we look at these, this network, as you can see, there's quite a few positive connections, but there are also some negative connections. Now compare that to what we see in patients, and right away, it's clear that there are more negative connections in the patients than there are in the controls. So when you directly compare patients to controls, so now what you're looking at is red is significantly stronger in the controls than the patients, and cool colors, of which there are none, significantly stronger in the patients than the controls. You see that, again, there is this left hemisphere lateralized stronger connection set of nodes for the controls, no surprise there. But what's interesting is that when you get to these bilateral frontal regions and right hemisphere regions, that difference between the controls and the patients is actually lower than what you see in the left hemisphere regions. Now, that's actually not that different from what we saw in the SIM study, where we found that healthy controls had this left lateralized network, but patients were more reliant on this bilateral frontal regions, and that would explain why the difference in these nodes is not as stark as what you see here. So again, it seems to be that this network is changing, but it includes this bilateral frontal and right temporal regions. To what extent they're actually doing the job, we're not sure yet. So this is before treatment, and then Jeff also looked at this data after patients received our usual semantic feature-based naming treatment. So now they're getting 10 weeks of treatment, and we're looking at percentage of improvement of naming on atypical examples versus an control set, and you can see that the patients improve on the trained set relative to monitored set. And this is the same graph picture that I showed you before, where we're comparing healthy controls to patients before treatment. So you're looking at that. You're looking at something you already saw. But this is the comparison after treatment. So what we see here now is before treatment, there's quite a bit of difference between the controls and the patients, especially in the left hemisphere regions and this bilateral frontal network. But after these 10 weeks of treatment, that difference here goes away. And the amount of difference that we see as such between controls and patients has reduced quite a bit. That seems to indicate that we're seeing some sort of normalization of the network. Of course, these are just the first data that's coming out. We're planning to do a lot more analyses of what's actually happening at each of these nodes. But I should point out that we're not the first people to suggest that what we're seeing is a normalization of the network as a function of treatment. In fact, there have already been studies by Sarasso and Van Hees et al. That suggest that one of the things that happens after treatment in patients with aphasia is that they become more normal-like, and the difference of that, all that hyper or abnormal connectivity that you see is sort of going away, is normalizing as a function of treatment. So there's a lot more work to be done in here. We have started to look at changes in the structural predictors as a function of treatment. We've started to look at node level metrics, but clearly the story is not complete, but at least we feel like there's something to stand on there. Now, that was just looking at neural markers. We have spent a lot of time trying to understand what cognitive aspects and language aspects would also predict treatment outcomes. As you know, of course, people's performance on different language abilities influences the extent to which they're going to improve in treatment. But more importantly, we've started to see that attention abilities, their learning abilities, their ability to monitor cognitive control, as well as their existing executive function abilities also determine the extent to which they recover language and the extent to which they improve after treatment and after language treatment. So I won't go into much of that now. The other thing that we've spent a lot of time looking at is coming up with treatments that actually work for these patients. So you're familiar with all the work that we've done looking at lexical access and treatment for reading deficits and sentence processing deficits that include verbs and sentence comprehension. We've also taken a lot of that treatment and put them into an iPad software so that people can receive the same kind of therapy and in more, sort of prescribed ways. We've also tried to see if all this treatment does indeed change individuals' ability to functionally communicate in everyday situations. So I'm not going to talk about any of this because what I really, where we are at with that work is we do know that the treatments that we've been developing work, but we don't know which treatments work for which patients. So we're still sort of struggling, trying to figure out the right treatment for the right patient, even though we have treatments and we have patients. So we haven't made that connection completely yet. And that sort of brings me to the second part of my talk, which is looking at how can we take this information and use it to develop algorithms that would actually predict the extent to which patients can improve as a function of treatment. All right, so here we're actually looking at it, again, this is ongoing work, so it's not complete, but there's some initial indications of what we've started to look at. So in this case, we're looking at it two ways. We're looking at whether we can use computer evolutionary algorithms to predict treatment outcomes in bilingual aphasia, because that's something we care about. And we're also trying to use population analysis of big data to then do cohort levels analysis and then predict individual treatment outcomes. So I'm going to tell you a little bit about both of these kinds of work that we're doing. So the first question that's very important to me is what language do you treat patients with bilingual aphasia in? Do you treat them in English or do you treat them in their native language? And this is a really gnarly question because there's so many factors that influence the way you can understand a bilingual person with aphasia. They learn languages at different age, they're exposed to it at different levels, they use it at to different degrees, their family's proficiency is different, they've learned it differently, their education is in English or not, and all of these roll into a heterogeneous set of factors that you have to contend with until the person has a stroke. And then once the person has a stroke, now you're dealing with a whole set of factors that we're more used to seeing in aphasia, which is in the actual post-stroke impairment. And so to what extent these things interact and influence each other is actually very, very complicated. And I think it's beyond our ability to look at this in individual patients. So what we've tried to do here is sort of take a completely different approach to the problem. And this was work that we had already done in a previous grant where we had developed a computational model that had a semantic map and two phonetic maps, one in English and one in Spanish. And this model was essentially trained to behave like a bilingual adult. In a grant that we're working on right now, we've extensively updated this map. It uses evolutionary algorithms to come up with optimized models. And what we're doing here is we have semantic maps with category boundaries, and we have phonetic maps with phonetic boundaries that are all represented in English and Spanish. Then this model that's been developed to behave like a bilingual is then asked to name pictures in English or Spanish, and we compare the model's performance to actual human healthy bilingual performance. Sorry, that's going too fast. And what we find here, and this is data from 21 adults, and we've just finished the cross-validation of this on a new set of bilingual adults. And the model does a pretty good job predicting what the actual naming performance in the human adults would be. Then we take that model, now that we know how to simulate a bilingual person, and lesion the model to simulate deficits either in pyramids and palm trees or in our naming screener that's administered in English and Spanish. So this is just data from one person, but we've done this now for 22 patients that we had collected from before. And the idea here, so the horizontal lines here are the actual patient performance, and on the x-axis you see what increasing damage does to the model. And I can come back to these dotted lines later on, but the idea here is that based on the amount of damage you introduce into the model, you can pretty accurately predict semantic deficits as well as naming deficits. So that's how far we've got. Now we're really trying to take this and use it to predict treatment outcomes. This is actually a graph from our previous project where once we had a model set up this way, we were able to predict recovery. So this is after treatment that the model would estimate what the outcomes would be. And in the previous project, we were able to then compare patient data to the model data in a sort of post hoc fashion and say, yep, the model did a good job explaining the patient's performance. But now we're really trying to do this as a predictive approach. So we first get the computational model's outcome, and then we treat the patient and we see if the model got it right. So that's really work we're starting to do now. So stay tuned for more of that. Okay. So the point of this is that we can actually take all these parameters that I called completely unyieldy before, such as age of acquisition, language proficiency, level of impairment, so forth, and then use it then to understand the level of impairment in patients, and then of course predict treatment outcomes. And we obviously expect that not all patients would show these nice rise curves. We expect the model to adequately capture when you will not get benefit when you train a particular language, and when you will get benefit training another language. Okay. So that's one way we're looking at this predictive outcome. The other way we're looking at it is using this population analyses, and here we've really been fortunate to get a lot of data. And again, this is a very complicated problem because, as I presented at the beginning of the talk, there's so many factors that influence how a person is going to improve, including lesion location and time post-stroke. But in addition to that, there are several other factors, such as the treatment itself, the intensity of treatment, the optimal dosage, the type of treatment, and so forth, that also would influence the amount of outcomes that you see. And because we've been able to deliver therapy using the software, we've collected a lot of data. I'm not sure how many of you are familiar with constant therapy, but in this case, the clinician signs up for an account and enrolls patients, and then assigns very individualized therapy plans for each patient. The patient logs in and does a therapy task at home, and the clinician has access to all this data. And over the last 4 years that we've been, people have been using constant therapy, we've collected a lot of data. And so the data that I'm going to show you in the next couple of slides is essentially coming from about 20,000 stroke patients who have used the program. And that gives us some abilities to start to really tackle these questions about, what does severity of impairment mean to therapy outcome? What does intensity of therapy mean, and so forth? So the first question that I'm going to just show you today is, how does the severity of impairment influence whether patients improve in treatment or not? So for this analysis, we've looked at about 12,000 patients who've done 244 unique therapy tasks that are available to them in constant therapy. And we've tried to plot how much severity and practice interact. So in this graph, what you're looking at is essentially lines of patients who are binned based on their initial performance. So this blue line here are very severe patients. Their starting performance is 0 to 40%. The green line are patients from 40 to 50%. The beige line is 50 to 60, and so forth. So the red line here are really mild patients from 80 to 90% accuracy. On the y-axis, you're looking at the gain in accuracy on any given task, and on the x-axis here, you're looking at how much items they actually practice. So here they practice 13 to 23 items. Here they practice 33 to 100 items. Here they practice 500 items, and so on. And what you can see right away is that the mild patients don't need that much practice, and they don't show that much gains either. The ones who this therapy and this extra practice is really useful for are the severe patients. They're the ones who have more to gain, and they're the ones who show more gain. So of course the question is, are you just seeing a ceiling and a floor effect here, where the patients who are already at 80 don't have much to go, and these guys have a lot, they have a long way to go. So we flip the analysis and we say, how many of these people actually end up mastering the task as a function of practice? So anything above 80% shows that they've mastered the therapy task. And again, the people who are already above 80% don't show that much gain. But what really matters here now is patients who are starting accuracy is 0 to 40% or 40 to 50% do actually improve. They do actually master the task. They get to over 80% accuracy, but they need a lot of practice to get there. They need a practice of about 500 items to get to that point. Nevertheless, these data suggest that even severe patients can improve as long as they practice quite a bit. The other question that we've looked at is what is the optimal dosage of treatment? And this is an issue that's quite a big but unanswered question in aphasia rehab, is how much therapy should patients get? How often should they practice? And so forth. And so here again, just to put things in context, according to ASHA, the ASHA norms, 78% of the patients with stroke will receive either 2 or less sessions per week when they're getting that rehabilitation. So what we tried to do here was look at patients, and this data includes about 1,800 patients with aphasia. 1,000 of them are in the acute stage and 700 are in the chronic stage. And now we're trying to see how much practice do you need? What is that optimal dosage? So here is data from one domain. I'm just going to show you, this is the reading domain. And on the y-axis here, you're looking at the difference from the baseline domain score. So in the reading domain, we calculate domain scores. A lower score here means they're struggling on very simple tasks like matching single words. The higher the domain score, the more complex their reading abilities are, such as they're able to read sentences or paragraphs and so forth. On the x-axis, it's just weeks of therapy, so 4 weeks, 8 weeks, and 12 weeks, and that's typically how long we do our treatments. And every one of these lines indicates how much practice they do per week. So this line here is less than 1 day a week. This line is 1 day a week. This line, the yellow, is 2 days, 3 days, 4 days, 5 days, 6 days. And as you can see, there are essentially 4 functional dosage groups here. And it's clear that after 3 months of practice, participants who practice less than once a week show significantly slower progress through the various domains compared to people who practice greater than 3 times a week, 4 times a week, and of course much more than that. So this gives us an idea of where the maximal gains are, at the same time where the diminishing returns are. There doesn't seem to be that much difference between practicing therapy 4 times, 5 times, or 6 times a week. And then finally, we want to get to really predicting that individual performance. So here's population analysis, where if we take the reading domain and we start to look at patients who've all done this reading task at the starting point. So these are 755 patients who are all struggling with the basic task, which is identifying word categories. After 2 months of therapy, 51% of them have moved on, have made progress and moved on to other more difficult tasks, and the top 10% of them are able to match a feature to a given picture. So that's word phrases. After 4 months of therapy, again, 64% of them have moved on to other tasks. The top 10% of them are able to complete a passive sentence. And after 6 months of therapy, almost 70% of them have moved on to other tasks, and the top 10% are now able to sequence a series of sentences in terms of functional activity. So this allows us to now take a patient at the starting point, track how much therapy they need to practice in order to get to wherever they might get to on this functional level of reading ability. Again, we're not there yet, but this is where we're going with the sort of analysis here. So I hope I sort of gave you some updates on the work that we're doing right now. This is not work that's nearly complete, but the idea is that as we start to get closer and closer to nailing down some of these markers, we will actually be able to better predict outcomes for individual patients. And the idea is that when we get to this point of being able to predict prognosis and recovery for individual patients, the therapy recommendations that we provide to them will be much more informed than the little bit of a trial and error that we're doing right now. Okay, so I think I'm going to stop there and take questions from the group.
Let's start with some questions from our room. And Swathi asks that you please identify yourself. So when I was wondering, when you talked about the model in relation to Aaron Meyer's dissertation, the first step was you predicted that people with anterior damage would have most severe problems, and then you said posterior damage less severe. And it struck me kind of that there was a kind of a discrepancy between how you talked about that and how you then later on talked about therapy, where it was much more specific to types of disorders. So my question, I think, is, are you really sure that you can make such a, isn't that statement too general to just say that the aphasic deficit will be less severe in cases of posterior damage versus anterior damage? Doesn't that depend on the type of deficit that you're looking at? So, for example, in our current lesion symptom mapping analyses, we get a lot of posterior damage that actually predicts agrammatic production and things like that.
Sure. No, that's a really good question, and I don't think I'm thinking that that this really breaks down in terms of specific subtypes of aphasia. Certainly in the way we recruit patients into our study, as long as they're not apraxic, it doesn't matter to us if they're Broca's or Wernicke's aphasic in terms of their responsiveness to treatment or whether they improve or not. What really matters is whether they had anterior damage, posterior damage, or the sort of mass combined damage. So that's one answer, is that I'm not sure I want to tie this all to subtypes of aphasia in terms of how they improve. But I think your question is still valid, because you're saying, do you think this is too simplistic by saying it's just anterior versus posterior? And I think the way that the hypothesis that we're making now is that as long as you have MFG and IFG intact or spared or available, that means that you have posterior damage, but these regions are intact. Your chances at recovery are higher than if you didn't have those regions. I think that's really where we're starting. Now, how we modify that and how nuanced that actually is will really depend on how many other ways we can slice the pie and still get the same results. But that's really the starting point there.
Yeah, it would seem to me that if that's the case, and so then that would, to me, that would kind of imply that these regions then really support some extra linguistic propensity for recovery, right? Something that is more general. Mm-hmm. Does that fit with what you think as well?
It could very well be, and certainly that might be true of MFG, because MFG is involved in a lot of things, not just language processing. But it seems that when we look at language tasks, it certainly is active. But my colleague Fedorenko shows that it's active in other tasks as well. So that may be true of MFG. LIFG, I honestly don't know. It would be interesting to put it under some extra linguistic explanation, but maybe that, and if that was the case, that would be fine as well, I think. Yeah, I think that would I don't think the data here speaks against it at all. That you could be very well right.
Thank you. Any other questions from Laura? Yeah. You got to speak up. I can repeat the question if you want. Okay, so Danielle Fahey asks if you can explain the bilingual aphasia mental lexicon organization a little bit more. If you can talk about that more. Do you have any specific?
Are you asking about the model or the patient data?
Yes, please talk about the bilingual mental lexicon in aphasia a bit more.
Okay, so maybe I'll just go. I'll go to my slides and then you can ask me exactly. Oops, I went too far. So here, what we're only looking, just know that we're only looking at lexical semantic processing. That doesn't mean, you know, we think it'll apply across languages, but we don't know if it'll apply once we start adding syntax and phonology and other layers to this as well. We have phonology here for those specific words. So what we're doing here is that the question?
Yes.
Okay. So what we're doing here is we basically take about 600 words and their semantic features, and we have essentially set up the semantic map as a feature map. So every word here is a neighbor has its neighbor because it overlaps in its semantic features. And then in the phonetic map, this is just showing English, but we have a similar map for Spanish. Now every neighbor here overlaps in its phonetic maps, in its phonetic structure. So obviously this organization is very different for English as it is for Spanish. And what's critical here is that there are lateral connections between any two words here, and there associative connections, and you can see that here, there are associative connections between the semantic and the phonological map. The key thing here is that it functions like a recurrent network. So there's activation that comes in, it activates a bunch of features here, it activates the target, and it sort of goes through this loop. What I was saying, so when you start off with the map, and it assumes that you're learning a language at age 0, this particular map is completely undefined. It looks like one big blob of words. And as you expose the map more and more to English, and that's when the model is learning English, these maps get more and more defined. And with more training, with more exposure, with more input, the boundaries get more finite. So the way that it applies to bilingualism is if you take somebody who learns English at the age of 45 and you start with this blob, by the time you get to 15 or 20 exposures or 20 sort of exposure runs, the map is not as well defined as what you would see if you learned the language early. So that's where the distinction between different maps comes in, because the earlier you learn the language, the more exposure you have, the more finite and well-defined the semantic maps, the phonetic maps are. And then that just transfers over to performance later on. So I'm going to stop there and make sure that that's sort of what you were looking for.
Yes, that's great. Thank you very much. We have online questions. I'm wondering, Swathi, if you can see those in your chat box, or would you like me to read them out loud?
Okay, all right. Amy says, this is R.G. Hillis. That was a fabulous talk. Okay, do you ever think we will be able to identify and quantify all the variables that influence recovery at the individual level? If not, how much of the variability in recovery do you think we'll eventually be able to predict? What variables are the hardest to quantify? Yeah, that's a really great question, and I do not know if I even have a 20% answer to that. But I do think that I think we'll be able to quantify the neural metrics. I was, I'm talking to Leo this morning. I think that I think we have all of the neural measures sort of understood, or at least we'll figure out how to quantify those parameters. I think we'll figure out the language parameters as well. What I think is really hard is to quantify the social functional aspects of it. So I'll just take the bilingual data that we have right now as an example. We have very, very precise measures of their language proficiency. We ask them when did you learn your language? At age 6, what language were you speaking? At age 12, what language were you speaking? At 8 o'clock in the morning, what language do you talk? At 9 o'clock, who are you talking to? Which language? And so we get very, very precise information. Despite that, I don't think we can actually quantify people's perception of their own language abilities. And that's a huge piece that we will never get for sure in bilingual aphasia, but we won't probably get it even in monolingual aphasia. So people's perception of their knowledge of a language is much better when they're educated in it, when they use it professionally, rather than when they don't. And I don't think we can put numbers on that. And as long as we don't put numbers on that or break it down, I don't know if we'll ever be able to predict those. So that's what I think is the challenge. But in terms of how far we need to get, I don't know if we need to get to 100% either. I think that the goal here is to get to just enough confident accuracy to say you're better off doing this kind of therapy versus that, but not actually shut the door on anybody. I think that would have, if we got to a point where we said nothing in this model tells us that you're going to do well, go home, I think we'd all be very worried. Okay, and then Kirana's question was, when you identified the left MFG as a recovery area, did all patients have perilesional damage, or was this area intact in some of them? I'm trying to answer whether it informs about the effect of therapy in perilesional areas. Yeah, so that's a really good question, and that's why I spent some time showing you how we calculate the activation and how we account for lesion, because for some patients it's intact. For other patients, MFG is not really an area that's damaged for a lot of the patients, but it might be for the patients with extensive lesions. So everybody who's included in this, in any of the analysis that I showed you, has activation coming from some part of that spared region. And that's, we make sure that after we account for the lesion and after we account for noise and after we correlate with the signal with CSF, if there's still activation coming from any region, then that's probably activation, and if that's perilesional, then that's perilesional activation. Okay, that's that. And Brianna says, I'm a student. This was a great talk. Do you think the use of pharmaceuticals to enhance neural growth, specifically in the left hemisphere, would further enhance therapy for these patients, especially for the more severe forms? Yeah, that's a really good question, but I don't know about pharmaceutical interventions yet. I think the next best promise really is TDCS and TMS. So a lot of what you guys at USC are doing with the TDCS treatment, that I think will be the first proof of concept that you can change the way the brain responds to intervention and not just behavioral stimulation. I think if we can show that effectively, then pharmaceuticals, which have a much more diffuse effect on the brain, will hold promise. I think until we show that you can actually change the brain's responsiveness to anything stimulating, not just behavioral therapy, is the first piece of evidence that we need. I don't know if that was the answer you were looking for. Okay. Other questions?
I don't think so, Swathi. Thank you very much. That was great.
Okay,
much
thanks.
Appreciated. Thanks everybody online.